This is the second lecture in our didactic lecture series. It's entitled Embryology and Anatomy of the Venous System. So I think it's very important that we go over this, especially for the fellows, because if you don't have an understanding of the anatomy, and when I say anatomy, I mean more than just the superficial system, you're not really going to be a subject matter expert. And it's important to understand these underlying embryology because you're going to see some of the anomalies that come of it. So let's get started. So today we're going to start with the embryology. We're going to go over abdominal and pelvic anatomy, upper extremity veins, and lower extremity veins as well. So let's start with the embryology. So when the two gametes come together and it starts to form an embryo, you basically have three layers. You have the ectoderm, mesoderm, and endoderm. The mesoderm is where the arterial and venous anatomy comes from, as well as the heart and the aortic arches, specifically the intermediate mesoderm. The paraxial mesoderm is where a lot of the blood branches come from. So the first thing that happens is when you get this plate of the ectoderm and endoderm is called folding. So you see here that this is the neural foramina, which is where your spinal cord comes from. And this medial plate over here, the lateral plate of the mesoderm, two holes form. One of these holes is going to become the heart tube, and the other two holes, this one here on either side, is going to become the dorsal aorta. The holes for the heart tube fuse together to form the four chambers of the heart. And then the dorsal aortic horns go through various changes that we're going to go through as well. So when you look at the tube that forms, it has various sections to it. So there's the aortic sac, the truncus arteriosus, the bulbus cordis, the primitive ventricle, the primitive atrium, and then the sinus venosus. So the sinus venosus is responsible for all the venous formations, and we're going to go through that in a moment. But I want to spend a little bit of time going through some of the aortic changes because you really can't fully understand the venous embryology without kind of putting that into context with the aortic embryology. So here's the aortic sac right here, and here's the two dorsal aortic horns. When VEGF gets stimulated here, you get these tubes that form. It goes through the endoderm, and then it connects to the horns. And what this does is this leads to the formation of the aortic arches. So there are 5 aortic arches. Actually, there are 6, but the 5th one regresses. So the first aortic arch forms the maxillary artery. The second aortic arch forms the hiatal artery. The third arch, which is probably one of the most important ones, forms the common carotids and the proximal internal carotid arteries. The fourth arch does the right subclavian artery and the aortic arch vessels. And then the 6th aortic arch does the right and left pulmonary artery, as well as this little structure down here, which is the ductus arteriosus. So these tend to be very frequent board questions, even on the ABVLM. So it's kind of always good to kind of review these aortic arches and where they come from. Now, going back a second. You see here both the dorsal aortic arches, they fuse to form the descending aorta. The descending aorta has several horns to it. So there's the distal lateral branch, and then the anterior lateral branch horns, the dorsal lateral branch, and then the lateral branch horns, and then the vitelline artery. The dorsal lateral branch horns become the lumbar arteries that go to the spinal cord. The lateral branch arteries become the blood vessels that go to the adrenal gland, the renal artery, and the gonadal veins. The vitelline artery forms the 3 major arteries of the abdominal aorta, which is the celiac, the superior mesenteric artery, and the inferior mesenteric artery. And then you get your internal iliac artery branches. And then in utero, the umbilical arteries, which are very important because they are part of the fetal circulatory system. All right, let's get to the veins now. So remember, we talked about the sinus venosus. So the sinus venosus has several important arteries. I'm sorry, several important veins, pardon me. So the most important veins you're going to hear about are the cardinal veins. So this is the right and left anterior cardinal veins. These are the horns, which we're going to talk about a little bit later when we talk about the abdomen. And then we have the posterior cardinal veins, and then we have the vitelline veins. So the anterior cardinal veins form your thoracic blood vessels, your innominate, your internal jugulars, and your subclavian. The cardinal veins are essentially responsible for your inferior vena cava and the branches of the inferior vena cava. And then the vitelline veins are part of the splanchnic vasculature, your inferior mesenteric vein, your pulmonary vein, your hepatic blood vessels. So this is another way of looking at the diagram. Here's the sinus venosus. These are your, this is your posterior cardinal vein. These are your supra, sub, and sacral cardinal veins. And then these are the anterior cardinal veins here. These anterior cardinal veins, I'm going to show you in the next slide how they form the jugular veins. So what happens is you have the right anterior cardinal vein, which stays intact. This portion of the left anterior cardinal vein regresses, and it sends in a branch, the anastomosis, to the right cardinal vein. This branch becomes your innominate vein. And then the posterior cardinal veins also dissipate and go away, and that's very, very important. So the final product here is you have the innominate vein, both of your internal jugular veins, and then you have the subclavian veins here. So all of these come from your anterior cardinal veins. And remember, down here, these little bulbous areas here, these are the horns of the sinus venosus. So from the horn of the sinus venosus is the common, the right horn common cardinal vein, and then the left horn common cardinal vein. These send two branches down to the liver, and this forms the right hepatic vein and the left hepatic vein. Now down here in the yolk sac, you have the vitelline veins. These vitelline veins anastomose to the small intestines. Then they coalesce to form the internal mesenteric vein, the splenic vein, and then your portal vein. So down here is the internal mesenteric vein, splenic vein, your portal vein. They anastomose to the into the sinusoidal veins. And then what happens is you get regression of this left hepatic common cardinal vein. It anastomoses to the right side. So this becomes your left hepatic vein, your right hepatic vein, and then this becomes your infradiaphragmatic inferior vena cava. And then also, you'll see on the next slide, from the placenta, the left umbilical vein then anastomoses to the intrahepatic veins, but it sends another branch directly to the inferior vena cava through the ductus venosus. This is what you remember from medical school as your fetal circulation. And this is done so that you have a low flow, low pressure venous system. And then at birth, this ductus venosus goes into spasm, and it causes these other blood vessels to dilate and come online, along with the ductus arteriosus. Okay, so splenic vein, inferior mesenteric vein, portal vein, hepatic veins. These veins here come from the common cardinal vein off of the horn. The left side regresses, and you get the left and right, and then you get your infrarenal inferior vena cava. So going back again, so then we have the sinus venosus. You have the anterior cardinal veins. This part regresses and the posterior cardinal veins regress, and then you get this normal anatomy. And then what's the frequent test question on the ABVLM is what I'm going to tell you right now. The cardinal veins, remember I told you the posterior cardinal veins regress. You have these ones here in the middle, and they're broken up into three segments: the supra, sub, and sacral cardinal veins. So let's go through them one by one. The supracardinal veins, which are in green, these are the veins that form your azygous and hemiazygous system. Okay? And then the subcardinal veins, these are the ones that form the middle part of the inferior vena cava, and they send branches to your adrenals, your renal, your kidneys, and your gonadal veins. All right? So this is the, go back, subcardinal veins. Okay, frequent test question. Then you have your sacral cardinal veins, which forms the iliac veins, the beginning of the inferior vena cava. Okay, so remember this. Anterior cardinal veins do all of the thoracic stuff. You have the supracardinal veins, which form your azygous and hemiazygous system. You have your subcardinal veins, which form the blood vessels, the veins that go to your adrenal, kidneys, and your gonadals. And then the sacral cardinal veins do the iliac veins and the inferior vena cava, the sacral portion of the inferior vena cava. This diagram here is probably 3 or 4 test questions. So looking at it in a different way. So this is your posterior cardinal veins. These are the ones that regress. These are your subcardinal veins. And you can see here how they form the middle part of the inferior vena cava, veins to the kidney gland, to the kidneys, and then your adrenals. And then here, this is the sacral cardinal vein, which forms the iliac veins in the infrarenal portion of the inferior vena cava. So on venography, this is what it looks like when you have incomplete formation of your blood vessels. This is a duplicated inferior vena cava. You can see here how the right side didn't form very well. You have a predominantly left-sided supracardinal vein. You can see here how it anastomosis to the left renal vein. So this is what a duplicated inferior vena IVC looks like. Here's a left-sided IVC. So the right subcardinal vein regressed. The left subcardinal vein stayed here as the main portion. Again, this is the renal vein. Here's the right, the right renal vein, the left renal vein, and then so this is a left-sided vena cava. Now we also have something called a persistent sciatic vein, which you will see on duplex ultrasonography. The sciatic vein arises from the popliteal vein and its tributaries. It goes on the posterior aspect of the thigh, and it follows the course of the sciatic nerve. It terminates by draining into the internal iliac vein, and that's very, very important. And you have 3 variations of this vein. You have a complete sciatic vein, which goes from the knee through the posterior thigh, past the inguinal ligament, and into the internal iliac vein in the pelvis. You have an upper portion, which is just in the thigh and internal iliac vein, and then you have a lower portion, which is just the distal and middle portions of the thigh. So this is the variation. So here's a complete, here's an upper. You can see here for the profunda just to the internal iliac, and then this is just a lower where it's from the popliteal vein into the profunda, and it stays below the inguinal ligament. If you look at it, why is this important? This sciatic vein often becomes aneurysmal. So you might have an aneurysmal vein, and you see that it arises from the popliteal. It goes all the way up the posterior thigh into the internal iliac. That's a complete sciatic vein. Here's one just in the upper thigh. But again, it anastomosis into the internal iliac. And here's a lower sciatic vein aneurysm, which stays basically below the inguinal ligament. On duplex, you can see here, here's one where you have a duplicated femoral vein that happens 30% of the time. Here is a sciatic vein that's aneurysmal that follows the course of the nerve in the posterior thigh. And here is the femoral artery. So this is what it would look like on a duplex scan if you saw a patient like this. All right, so that's the embryology. Let's go over some of the venous anatomy that you should be familiar with. So suprarenal inferior vena cava, renal veins. So the right and then the left, and then here is the left gonadal vein. So 90% of the time, the left gonadal vein anastomosis to the left renal vein. And over here, the right gonadal vein, 90% of the time, anastomosis to the inferior vena cava directly. 10% of the time, it goes to the right renal vein, and 10% of the time, the ovarian vein on the left actually anastomosis to the inferior vena cava. This is the left common iliac vein. You can see here the right common iliac artery crosses over the left common iliac vein. This is what it looks like in a human. So that is your infrarenal inferior vena cava. That is your infrarenal aorta and with the bifurcation. Left common iliac vein. This is actually your ureter. The ureter crosses over the left common iliac vein. This is your left gonadal vein. All right. So when we look at the pelvic venous anatomy, you have something called an ascending lumbar vein, medial sacral vein, and your iliolumbar. So this vein here that comes off of the common iliac that goes to the sacrum is your medial sacral vein. These two veins right here, which come off of the common iliac veins, and they go north or they ascend, when it's below the diaphragm, they're called ascending lumbars. When it goes above the diaphragm, it then becomes the azygos and hemiazygos venous system. And then your iliolumbar goes through to this part of your pelvis to provide venous outflow to the iliac musculature. Another way to look at it, again, infrarenal IVC. This is your ascending lumbars. Sorry about that. That does every time. So left ascending lumbar, right ascending lumbar. Here's your diaphragm. Here's your azygos system and your hemiazygos system. And we learned that this, right, comes from the anterior. I'm sorry, not the anterior. This comes from the supracardinal veins. Pardon me. This is your anterior cardinal veins up here. All right. External iliac veins. You have the inferior epigastric and the deep circumflex. So the inferior epigastric anastomosis with the superior epigastric veins, it basically, this is the one time when you look at it on duplex scan, blood flow is going to be going in a descending pattern into this system going up. So when you look at this, when we're doing our ablations and you see the inferior epigastric vein, you're going to see blood flow going towards the probe and it'll be a different color, all right? Your deep circumflex veins come off of the external iliac, and they anastomose with the lateral sacral veins up here at the top that we showed earlier. Okay, so what does the ascending lumbar vein look like in venography? So here's someone who has an inferior vena cava occlusion. You can see that there are two vena cava filters here. This is a very dilated, large ascending lumbar vein. When you have an IVC occlusion, this is your collateral pathway. You can see here, this is there's synechii inside this vein, and this is a huge right ascending lumbar vein. Here's another filter, which is very, very low, which caused this vena cava to occlude. And then this is what it looks like as with the occluded inferior vena cava. You have your ascending lumbars, and they're going to form the azygos. This is the main outflow, venous outflow for this patient who has an occluded inferior vena cava from filter placement. All right. Now, the internal iliac vein anatomy is very, very complicated. And we don't spend enough time going over this. So I'm going to actually kind of go through this in a little bit of detail. So stick with me. It's a little difficult. So when you look at the internal iliac vein, there is a common trunk. The common trunk splits into a posterior branch and an anterior branch. The vast majority of the branches of the internal iliac vein come off of the anterior trunk. There are only 3 branches on the posterior trunk, but they're important branches. So they have your iliolumbar, lateral sacral, but the most important one is the superior gluteal branch. And right here, this muscle here, this is your piriformis muscle. So this is a very important muscle because it can cause sciatic pain, but it'll also give you a clue as to which veins are involved when you see varicose veins in the buttock region. So let's go with your iliolumbars. The iliolumbars travel up the iliac or the pelvis, right? And they're on the surface here of the piriformis muscle. And as you can see here, it travels up the iliac pelvic fossa, and then it also goes up the spine to give you a iliosacral or iliolumbar, pardon me, branch. So here's your iliolumbar branch. Here's the iliac branch from the posterior trunk of the internal iliac vein. So this branch here is your lateral sacrals, and you can see here it goes right to the sacrum. So that's pretty easy to remember that one. But then finally, the most important one here is this branch right here. This is your superior gluteal vein. And you can see here, there is a little opening right here from the piriformis and the sacrum, and that's where the superior gluteal vein passes through here, and then on its way towards the gluteal veins. All right, and you can see here from another different angle from the other side. This is the posterior side. You can see here the sacrum. This is the piriformis, and then it's traveling towards the gluteal veins. So what does this look like? When you will see people who present to your office that have these varicosities on the buttocks right here. When you see buttocks varicosities like that, that is a superior gluteal vein origin. And this is what it will look like on the duplex scan. So again, going back here, here's your sacrum, here's your piriformis. The superior gluteal comes from the top part of the piriformis. The inferior portion of the piriformis is where the inferior gluteal vein comes from, and I'll show you that in a moment. Okay, now the anterior branch of the internal iliac vein. It has 7 branches to it. You have your umbilical, superior vesical, obturator, inferior, vaginal, middle rectal, internal pudendal, and then inferior gluteal and uterine. So many, 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 many branches. So the obturator branch, if you were a vascular surgery fellow, this is probably one of the most frequent questions you get, because right here, I don't know if you can see it very well, but this is the obturator foramen. The obturator artery and vein pass through the obturator foramen, and they pass through the superior portion of the foramen. The reason why this is important is because if you ever had to do an obturator bypass, you don't want to injure the artery, vein, and nerve. And you're always told that you should go into the inferior portion of the obturator foramen so that you don't injure this blood vessel here. And as you can see, once it goes through the obturator foramen right here, it sends this big looping branch here to cover the obturator portion of the muscles in the obturator foramen. Okay, then you have your umbilical branch, which usually deteriorates. And then you have your superior vesicular branches, which sends you an outflow for your bladder. And then you have your inferior vesicular branch, and then you have your middle rectal. So here's the middle rectal, inferior vesicular branch, superior vesicular branch. Then you also have, in women, obviously, there's a vaginal branch. And then the internal pudendal vein, or the internal pudendal artery, is the last vein of the anterior trunk. And I'll show you what that looks like in patients who have pudendal vein varicosities in a moment. And then here, the inferior rectal branch right here, like I said, this goes below the piriformis muscle. And when it exits into the skin, it shows up in the crease between the buttocks and the thigh. So if you see varicosities that emanate from, it looks like the buttocks, but it's right at the buttocks crease, that's from the inferior gluteal vein. All right. And then finally, the internal pudendal, like I said, is the last branch of the anterior branch of the internal iliac vein. Now, there are very, very common anomalies of the origin of the internal iliac. I'm not going to go through all of these. I just want to show you a couple. So number one is the normal anatomy. This one here, where you have a high takeoff of the right internal iliac vein, almost near, it's coming off the common very, very high. It's not at the same site or length as it is on the left. This is the same thing. So you can have a high takeoff on the left as well. 3A is probably the most common variation that I've seen when I'm doing venography, where you have the right internal iliac vein is actually coming off of the left common iliac vein. This is a very, very frequent finding, and it causes confusion sometimes, especially when you're doing iliac vein stenting, because you can cover the iliac veins, which is fine, but this oftentimes causes confusion when you're trying to find the internal iliac vein. And when you're doing balloon occlusion venography, if you don't recognize that this is actually the right internal iliac vein, you're going to be searching for a long time. So high takeoff of the internal iliac vein, either on the right or the left, very, very common. And then a right internal iliac vein coming off the left common iliac vein is also a very common anomaly. Now, ovarian veins. So the ovarian veins is actually a anastomosis of many, many veins. So down here in the pelvis, near the uterus and the broad ligament, you have multiple venous segments, usually about 3 or 4 of them, that come together right around the L2 segment of the spine to then merge into one vein, and that gives you the left and the right ovarian veins. There are multiple anastomoses between the ovarian veins, the broad ligament, the uterine veins, the presacral veins, and the internal iliac veins. And I'm going to show you some examples of that in a moment. Like I said, on the left, the majority of times, at 99 or 95% of the time, the left ovarian vein or gonadal vein, anastomosis to the left renal vein. And on the right ovarian vein or right gonadal vein goes directly to the inferior vena cava. The normal diameter is usually around 3 millimeters. When you get to be above 6 millimeters, there's a high incidence of pelvic congestion syndrome. And the ovarian veins do have valves in them, many, many, many valves. So when you get reflux in those valves, that also leads to pelvic congestion syndrome, or now what we call them pelvic venous disorders. So this is an MRI. So you can see here, this is the inferior vena cava, common iliacs. This is a dilated left ovarian vein. You can see here, there's multiple venous segments here that come together to form the one ovarian vein. These are uterine veins. So there's reflux here from the ovarian vein through the pampiniform plexus into the uterine veins with crossover over to the right side. And you can, and then here's your left renal vein up here. So this is what a selective venogram looks like. So this catheter is coming in from the right into the left renal vein, into the left ovarian vein. The catheter is parked right here. Contrast is being injected, and you can see here this large network of uterine veins. Here, down here at the broad ligament, again, multiple veins that come together to form the one vein. This is a selective right ovarian vein. And again, you can see here that there's reflux into the uterine venous system. Here, these are coils. This vein was coiled on the left. So here's a live venogram showing massive reflux. You can see here the very dilated left ovarian vein. Show it one more time. Left renal vein, left ovarian vein, and then these are renal vein branches into the pelvis. This is now at the L2 segment. Multiple branches here, broad ligament. You can see here, again, uterine branches. These are sacral branches here, but in a moment, you see this up here, those are actually your iliac veins. So you can see here the rich network of veins that exist in the pelvis, especially in the female anatomy. These cross sacral veins are normal. So if you just saw this by itself, it would not be an indication of reflux. But you can see down here this huge network of veins in the pampiniform plexus that comes from the ovarian vein. And then here, this is actually your internal iliac veins. And up here is the right ovarian vein. So it goes from the left, pampiniform plexus, uterine veins, right ovarian vein, into the anterior branch of the internal iliac, and then up into your iliac system. So this is what a dilated ovarian vein looks like in real life. So that's your uterus. That's your ovary connected to the fallopian tube. And you can see here a large dilated varicose ovarian vein. Now, the internal iliac vein, especially in the common iliac trunk and the common trunk, is valveless. Distal to the common iliac, especially the branches of the anterior and posterior branches, they do have valves. So it's very, very common to see reflux into the common iliac vein, into the common branch of the internal iliac vein, but after that, there are valves. And so you really shouldn't see a lot of reflux. So now this is some selective venography that's done with balloon occlusion venography. So this occluding balloon is in the left internal iliac vein. And what you can see here, that through the anterior branch, the obturator vein is going through the obturator foramen. It's sending this branch right here, and it's actually anastomosing to the great saphenous vein. So another balloon occlusion venography into the internal iliac. And what you're going to see here is this is actually the pudendal vein. And right there, this is the great saphenous vein with reflux coming from the internal pudendal vein. So again, these are coils in the ovarian veins. This is balloon occlusion venography, but this is now in the posterior trunk of the internal iliac vein. And what you can see here is inferior gluteal veins also anastomosing to a great saphenous vein on the right. And this is sciatic vein varices. This stuff we already went over. We don't have to go through this again. What I'll say is if you see veins in the pubis, vulva, or labia majora, think obturator vein round ligament, inner thigh or posterior vulva, internal pudendal and ovarians, gluteal veins or posterior medial, think about gluteal and internal pudendals. So here's an example. So this is a patient of mine. You can't see it very well, but there is a vein that's emanating right from the crease, right below the buttocks here. This is an internal gluteal vein reflux. And typically what happens is it goes into the crease, it then sends a branch up here, it goes down the lateral thigh all the way down into the calf. And this is what a bulging vulvar varicosity looks like in a patient. This is a transabdominal varicosities. You see this when there is a common iliac vein occlusion. So the common femoral vein sends a branch up through the inguinal ligament. It goes across the pelvis, anastomosis to the right common femoral vein, and then goes through the unobstructed right side. So whenever you see abdominal wall varices just down in the lower part of the pelvis and nowhere else, there is by definition a outflow obstruction someplace. This is what internal pudendal vein varices look like. These are called high thigh varicosities. When you see these high thigh varicosities in a patient, especially if they're complaining of pelvic symptoms, they've got a pelvic venous disorder, and these are pelvic vein varicosities. So this is called outflow or exit vein, exit veins. Now, the great saphenous vein has multiple branches at the junction, all of which can anastomose with either the abdominal wall or through the pelvis. And we'll show some of those branches in a moment. Now, this is what we're used to looking at every day, right? So here's your common femoral vein. This is the saphenous vein at the saphenofemoral junction. Right here, you don't see it, but this is where the deep femoral or profundifemoral vein should be, but there's no reflux here because there's a competent valve. Here is your popliteal vein down here. It bifurcates into your deep femoral vein and into your femoral vein. And then here we see a very common anomaly. This is a duplicated popliteal vein. You see this in about 30% of patients. We also see duplicated femoral veins in about 30% of patients. So you're going to see a lot of this if you do enough duplex scans. And then finally, these are the paired tibial veins, right? We have the posterior tibial, perineal, and you don't see the anterior tibial, but they're always paired. So in 2005, there was a consensus conference in Rome in which to come up with a common nomenclature. So you're no longer going to see the term greater or long saphenous vein. It's now called the great saphenous vein, right? You're not going to hear the word short, smaller, or lesser anymore. It's the small saphenous vein. So great and small. So the great saphenous vein lies in its own fascia, right? As does the anterior saphenous vein. Drains from the dorsum of the foot, medial calf and thigh, and it's the saphenous nerve is very close from the ankle to the mid portion of the calf. It's only about 10% of the return of the venous system, but yet when it refluxes, it can cause symptoms. So again, this is the small, you see this LS, obviously this is an old venogram because this is referring to the lesser saphenous. Right now, remember, we always call it the small saphenous. And here you see the small saphenous anastomosing to the popliteal vein in the popliteal fossa. And then here, these arrows are actually pointing to perforator veins that connect the superficial system to the deep system in the lower calf. Now, remember, I alluded to the 5 branches at the saphenofemoral junction. You should be familiar with this when you're taking your ABVLM exam. You will get a question on this. So you see here that you have the superior circumflex, superior external, yada, yada, yada. So I'm not going to spend a lot of time on this, but you should be familiar with it because these can be sites where pelvic veins anastomose to the saphenous vein through these branches up here. The most common branch that causes recurrent varicose veins after an ablation is the anterior saphenous vein, which is the branch of the great saphenous vein. So again, this is the most common anatomy. So we no longer call it the anterolateral saphenous vein, we call it the anterior. The posterior saphenous vein is the site where the vein of Giacomini anastomoses with the thigh extension. The superficial external pudendal or epigastric veins. The epigastric veins are abdominal wall veins. This is the vein you see on duplex when we're trying to position the catheter at the saphenofemoral junction. Remember, I told you flow is in the opposite direction here when you have a draining superficial epigastric vein into the femoral vein. So surface anatomy. You see these bulging varicosities here, medial thigh. This is a classic tributary branch varicosity of the great saphenous vein. Another classic appearance of the anterior saphenous vein starts from the branch of the anterior saphenous vein in its own fascia. Typically, it will go down the anterior part of the thigh for about 5 to 10 centimeters before going laterally into the thigh and then down into the calf, and it can even go into the posterior portion of the calf. Remember, high thigh varicosities. You don't get fooled. These are not varicosities from the saphenous vein. If they're very, very medial, this is an internal pudendal vein varicosity coming from the pelvis, probably because there is a pelvic outflow obstruction someplace. If you see this pattern, think of the anatomy of the abdominal pelvic veins and think of a potential outflow obstruction. Now, this paper, if you guys have cameras or your phones, take a picture of this paper. Every one of the fellows, you should get this paper and read it. This is the best description of non-saphenous superficial vein reflux. Now, I have this paper on the share drive, so you don't have to go searching for it, but I expect all of you to read this paper. And I expect all of you to talk to your attendings about this paper. So again, this kind of summarizes a lot of the stuff that we've been talking about here. So see this vein here that comes off of below the crease? This is an inferior gluteal vein, right? And you can see this is the typical pattern in the posterior thigh into the calf. There is you can get a perforator usually from the deep femoral vein that goes lateral. So this posterior lateral thigh perforating vein is very, very common. If you have a vein from the internal pudendal that goes into the vulva, it can then cross into the medial portion of the thigh, go posteriorly, and give you this pattern here. The sciatic nerve can have varicosities, and oftentimes you'll get people that will present with some paresthesias in the location of these posterior thigh veins. If you see this, have your tech do a duplex of the posterior thigh and look for the sciatic nerve because you may have sciatic nerve varicosities. This is another perforator off of the deep femoral that emanates from the posterior thigh. This vein is very interesting. This is the vein of the popliteal fossa. It typically comes off medially, and it is a tributary vein that comes directly off of the popliteal vein. And then another knee perforator vein. So here's an example of the vein of the popliteal fossa. This branch right here, on duplex scan, when you look at it, is actually coming off of the popliteal vein right here. And you can see this is a huge vein. When I see this, I tend to ligate this vein rather than just strip it or remove it. But Jose Almeida says he just removes it. I think that's a little dangerous. But when you see this configuration and the tech comes to you, this is a vein off of the popliteal vein. Classic presentation. All right, small saphenous vein anatomy. Variable termination, frequent test question on the ABVLM. It only anastomoses to the popliteal fossa about 75% of the time. This is a great paper from Kathleen Gibson. Describe this anatomy. The small saphenous vein can either anastomose in the popliteal fossa, high in the fossa, or low in the fossa. because it has a very variable termination. And then you can also get a thigh extension of the small saphenous vein, otherwise known as the vein of Giacomini. So here's what it looks like on duplex scan. Here's the classic small saphenous vein with the saphenopopliteal junction. It's also classic anastomosis with the popliteal vein, but there's also a thigh extension here. So you have the saphenopopliteal junction and a continuation into the posterior thigh with the thigh extension. Or you can have no anastomosis to the popliteal vein and just have the small saphenous vein continue to extend up the thigh as the vein of Giacomini. So this paper by Kathleen Gibson is pretty much a classic paper, and you'll see this if you do enough ablations of the small saphenous vein. So again, here, these are the variable anatomy of it. I'm not going to spend too much time on this. We already went through this. Now, I show this picture just to remind me to tell you that when we are performing an ablation of the small saphenous vein, this area here that Steve Elias has outlined is the gastrocsoleus complex. You never want to go below this with a laser fiber or a RF fiber, because the sural vein lies in close proximity to the small saphenous vein from the ankle to this area here of the soleal gastroc complex. If you place your catheter below this, there is a possibility you can get a sural nerve neuritis. So remember this to try to avoid cannulating below this point, unless you're going to do a foam injection and you only plan to ablate to this point. So I guess to be specific, you should never ablate below the gastrocsoleus complex so that you can avoid a sural nerve neuropathy. All right, perforator veins. Perforator veins, by definition, connect the superficial system to the deep system. Flow in a perforator vein is from the superficial to the deep. Reflux is when you get flow from the deep system into the superficial system, overwhelming the system. So as by definition, a perforator vein perforates through the fascia. So when you're looking at the veins on a duplex scan and the vein takes a 90-degree turn past the fascia into the deep system, that is by definition your perforator vein. So I'm not going to go through all the different names of it. It doesn't matter, other than 1% of the time when there is no superficial or deep reflux, you might see a very large perforator vein that is causing an ulcer. That is by definition a pathologic perforator. It has to be between 3 and 4 centimeters with reflux into the deep system. And it has to be in a patient who has C4, 5, or 6 disease. Otherwise, most perforators with reflux are asymptomatic and should be left alone. And this is just to show you, again, a classic paper from Dr. Labropoulos, where all the possible locations of perforators can be. So this is what it looks like on a duplex scan. Here's your B mode ultrasound. Here's your this little white line here is your fascia. Here is a superficial vein through a perforator going into the deep system, and it's always in close proximity to an artery. On color, again, you see the perforator with reflux, and here's your 2 veins right here. So this is what it looks like before you do a perforator ablation, and then a successful perforator ablation. You now see there's no reflux into the perforator vein, and all you see is just the two veins and the artery. Successful perforator ablation. This was just to give you some historical context when we were doing subfascial endoscopic perforator ligations. So this is just to show you what the perforator looks like. You can see here it's going from the superficial into the deep system. Here's your perforator veins. We used to put a clip across them, and then we would ligate them with the scissors, and then you would transect them. Thank God we don't do this anymore because it was a useless operation. This is the old Linton operation, which basically it was an open SEPS procedure where you'd make this long incision, you'd identify all the perforators, you'd ligate them, and it did absolutely nothing for the ulcer. But at that time, they were trying to figure it out. Okay, upper extremity veins. You will hear about the thoracic outlet and inlet. A common question on the exam is the location of the subclavian vein in relation to the anterior scalene artery muscle. The anterior scalene muscle attaches to the first rib. and the phrenic nerve lies on top of the anterior scalene muscle. So the subclavian vein is anterior to the scalene muscle, and the artery is posterior to it, and that's where the brachial plexus is. Here's another view of that showing the scalene on the first rib and the location of the brachial plexus. And here the phrenic nerve. This is important because when you're doing a first rib resection, you have to transect the scalene muscle, and you want to make sure you do not injure the phrenic nerve. Otherwise, you're going to get a phrenic nerve paralysis. So this is a patient who had a thoracic outlet because of a first rib compression. This person, unfortunately, had the stent placed before they decompressed the rib, and you see here there's a stent fracture. This vein here is actually the cephalic vein, and it's anastomosing to the superior vena cava and jugular vein. And then after they did the first rib resection and fixed the stent, now you see a normal outflow here. So obviously we have veins in the hands and in the forearms. I'm not going to spend time on the hands very much. On the forearm, on the radial side of the forearm is the cephalic vein. On the thenar side, or where your pinky is the basilic vein, and then you have this medial vein here, which joins here in the antecubital fossa to send a branch to the cephalic vein and the basilic vein. Sorry. So right here, this anatomy here is extremely variable. There's numerous variations that happen to this, but again, cephalic veins from the thumb up the forearm, it goes all the way up the arm. The same thing with the basilic vein, and this anastomosis to the deep brachial vein higher up in the axilla. This is very important when we were doing arteriovenous fistulas for dialysis. This is actually the radial artery, and this is the location of the basilic vein on this patient. So we dissected out the radial artery, tied off all the side branches, dissected the basilic vein all the way, tied off all the side branches. Then we made a tunnel to bring it superficial, and then we made an anastomosis to the radial artery, and though this is a radial basilic arteriovenous fistula, and then you can see here the superficial tunnel, and then this is what it looks like when it matured for easy access to for dialysis. So again, the cephalic vein travels up the arm, it goes into the deltopectoral groove, and it anastomosis to the subclavian vein high up here and below your clavicle. So here is the superior vena cava. This is the right subclavian vein. Right, here's your innominate, and here's your internal jugular. So, and then your axillary vein, this is from the deep brachial vein, and then it becomes the axillary vein, and it depending upon its location in relation to the pectoralis minor, you have either the supra or infrapectoral axillary vein. So the axillary vein, in relation to the pectoralis minor, differentiates when it becomes the axillary or the subclavian vein. So I'm going to stop right here. That was a whirlwind tour of the venous anatomy, as well as showing you some examples of anomalies that can come from when you have embryologic anomalies. I showed you what some surface veins look like, and then the normal anatomy of the upper and lower venous extremity. I showed you what some duplicated veins look like. I showed you the sciatic vein aneurysms, and that's just a smattering of examples of why it's important to know in great detail the embryology and the anatomy of the venous system. So I'm going to stop sharing right here. I'm going to open it up. Are there any questions from the group? You're all shell-shocked and stunned? Okay. So this lecture is on the shared drive. I updated it today. I added some stuff to it. I will add the updated lecture to the shared drive if you guys want to go back and refer to it. I would suggest at some point, at numerous points during your fellowship for the fellows, you go back and review this as you start to gain more knowledge. Okay, so not seeing any questions. Everybody have a wonderful weekend.